for the 20th TUGSS India Academy. For the new delegates who have joined for the first time, let me inform you that TUGSS India is this academic society which organizes monthly webinars, mainly on topics of GI and surgical oncology. And we have organized around 19 webinars, and we with eminent Indian faculties cover the surgical oncology topics. Now I'd like to welcome our TUGSS India Chief, Dr. Vikas Jain. Sir is a Senior Consultant, Surgical Oncology and Robotic Services at SCG Manavta Cancer Center, Nasik. He has been invited as a guest faculty in ASICAN and various other academic events. Welcome to the audience.
Hello, I'm audible?
So, yes, sir.
Yeah, okay. So thanks, Panin, to introduce me. As we all know, the TUGSS India chapter, we are running this webinar every month on second Friday of month on different GI-related topics. First time we have taken this colorectal theme and chosen best of our colorectal specialists for this today's webinar. In this series, I would like to invite our panelists for the sessions one by one. First is Dr. Shabnam Bashir, who is Senior Consultant Colorectal and Peritoneal Surface Cancer in Ujala Signes Kashmir Hospital in Srinagar. She has been academic advisor for Kashmir State Chapter of ASI, and she has been a co-founder of Colorectal Division at Apollo Hospital, Bangalore. She is a trained robotic surgeon from Matikuti Foundation. Welcome, Dr. Shabnam.
Thank you very much for that generous introduction, Dr. Vikas, and thank you for having me here.
Yeah.
Hope to have a great academic session.
Yeah, I hope so. Second is Dr. Prashant Chandra Das. He's a surgical oncologist in Apollo Cancer Centers, Bhubaneswar. He has been trained at Kidway Institute of Oncology, and he has a special interest in GI oncology and minimal access surgical oncology. He had been awarded Young Investigator Award in ICC 2017, and we are just about waiting for him to join. He's been joining in, I think, next 10 to 15 minutes. Our third panelist is Dr. R.A. Manidatta. He is a consultant radiation oncologist at Utkal Hospital, Bhubaneswar. He has been trained from Safdarjung Hospital, Delhi, and has completed his fellowship in AIMS, Delhi. Thanks to all panelists being with us. With that, I like to invite our first speaker, who is well known in surgical oncology societies, Dr. Praful Kumar Das, sir, who is the president of Indian Association of Surgical Oncology, and currently he is heading surgical oncology department as a dean and academic director in Utkal Hospital, Bhubaneswar, Odisha. With that, I hand over to Dr. Praful Kumar Das, sir, for his presentation on ERAS protocol in colorectal surgery. Praful, sir, welcome.
Much, Dr. Jain and Dr. Sanindra for inviting me for this wonderful webinar. So, sorry, my throat is bad, but I'll try to cover as clearly as possible. So, my topic is ERAS protocol in colorectal surgery. Welcome from Utkal Hospital and greetings from IASO. So, as you know, colorectal surgery historically has been associated long post-operative hospital stay, high cost surgical site infections, and enhanced recovery protocol as a set of standardized perioperative processes which are applied to the patients undergoing elective surgery only. Maybe some emergent or urgent patients, but not for the, yeah.
Sir, your screen is not visible. You share this.
Is it?
Sir, you have not shared the screen, I guess.
Okay.
Sir, in the center.
Yeah. Yeah.
Yes.
sorry. So it was screens. Let's see. Yeah.
Fine, sir.
So yeah. So ERAS protocol is a set of standardized radio-operated process which are up to the patients undergoing elective surgery only, and maybe for some urgent and emergent patients, but not for the non-elective cases. So it is known as fast track because it enhances the recovery protocol, enhances the recovery of the patient. Thereby, the patient goes early to the home. So pre-admission counseling is very important. Most commonly, it is in person, but despite of the benefit, in-person preoperative counseling can be resource intensive, which may limit its spread use. So prescripted phone calls may provide sufficient counseling while saving the resources. So if patient requires a cryosinostomy, it has to be properly counseled before the surgery because many a times it lands up in dehydration if patient is not well aware of its importance. So pre-admission nutrition is also important. Clear liquids may be continued up to 2 hours prior to the general anesthesia, as opposed to the conventional 4 to 6 hours before this anesthesia. So it has got an advantage because it creates a higher gastric pH and low acidity, thereby less complication. So this is being validated by ASA and ESI with recommendation. So carbohydrate loading also should be encouraged prior to surgery, especially in non-diabetic patients. So to encourage to attenuate insulin resistance. Supplementation of oral nutritional uh, protein intake about 1 to 1.5 gram per kg per day for a period of 1 to 2 weeks is associated with reduced post-op complications, and but the supplementation containing some immune modulating nutrients like uh, omega-3 fatty acid, arginine, etc. They are controversial. So mechanical bowel preparation with oral antibiotic has been the standard, uh, uh, which is incorporated into this ERAS protocol. Especially for the left colon, it is associated with decreased morbidity. And there is enough evidence which shows that use of mechanical bowel preparation with pre-op oral antibiotics, especially in elective colorectal surgery, is of great help in preventing infection. So prehabilitation is defined as enhancement of the patient's preoperative condition, especially with comorbidities, and which possibly improves the post-operative outcomes. So disciplinary collaboration is also needed between the surgeons. It's not the only surgeon, the nursing team, the anesthesiologist, the social workers, and the surgeons. So they form a multidisciplinary collaborative team, which should be who should take the important collaboration. Surgical site infection is one of the most common of measures in reduced growth in shower, mechanical bowel with oral antibiotics, antibiotic with 1 of and standardization of surgical field preparation with chlorhex or alcohol. Operative measures include use of protector, gown, and glove changing before the facial closure, using a dedicated wound closure tray, antimicrobial sutures uses, and most importantly, limiting the over traffic and maintaining the euglycemia and normothermia. So pain control is also very important. Uh, Mostly the opioids are minimally used, and they are used, especially NSAIDs, non-steroid steroid, anti-inflammatory drugs are used as a scheduled dose rather than SOS, and any spinal anesthesia with intrathecal morphine is more effective than the IV opioids. But concern is that they cause delayed respiratory depression. So one should be very careful about the post-op monitoring of those patients. Thoracic epidural analgesia has got no analgesic benefit, especially in lap surgery. So uh, preoperative multimodal antiemetic prophylaxis reduces perioperative nausea and vomiting. This is one of the most common complication after the colorectal surgery. So risks of for developing POM should be include female sex, history of POM, uh, non-smoking status, laparoscopic surgery, use of volatile anesthesia, etc. So there should be some strategies to reduce the risk of POM, include regional anesthesia or propofol-based total anesthesia without any volatile anesthetics. So common interventions are the DEXA with ondansetron, and they prove to be better from prophylaxis. Regarding fluid management, which is an important aspect of this ERP, restrictive fluid management is most commonly uh, 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 used, and with a zero balance fluid management, but there is slight increased risk of acute kidney injury. So overall goal there should be some positive fluid balance with 1 liter, around 1 liter, so that can avoid hypovolemia and AKI simultaneously. Balanced chloride restricted crystallite solutions should be preferred to normal saline. Colloids are not routinely used and they should be discouraged. Of course, they can be used in some setting of blood loss and when rapid resuscitation is needed. So there is increasing evidence that short duration of hypotension is also associated with myocardial and kidney injury. So individualized blood pressure management scores over standard pressure management, and in epidural block, crystalloid or colloid preloading is not typically required because they don't prevent hypotension. Rather, a low dose vasopressor can be used instead of any IV fluid in case there is a hypotension. So several meta-analyses of RCTs, they have shown goal-directed fluid therapy, which reduces post-op morbidity and length of hospital stay. IV should be routinely discontinued soon after the first post-operative day, or even within first post-operative day, uh, to enable the patient to mobilize early out of the bed. And minimally invasive surgical procedure also should be employed when expertise is available. If you go to the ALCAS and trial and color trial, laparoscopy is a superior uh, modality of uh, to open resection, especially when it is combined with ERP. So the optimal outcome comes in terms of enhanced recovery. So NGT is not required. In case it is required during anesthesia, it should be removed soon after the patient gets uh, out of anesthesia. And there is no benefit of routine use of intra-abdominal drains as opposed to the routine use uh, before 2012 guideline. And post-operative interventions also are important. Complications arises out of prolonged immobility. So usually within 24 hours or next day, at least 8 hours a day, starting from day 2, should be encouraged. And there is no harm in early mobilization. And also early feeding can be done within the 2 days, which really decreases the length of hospital stay and risk of complications. So ileus prevention also can be done by early feeding, and the patient really comes faster to normal. SAM feeding, which means using chewing gum on the first post-operative day soon after the patient is awake. So through saliva production and vagal stimulation, the bowel function returns early. So most of the available data supporting albumin in the setting of colorectal surgery is limited to open surgery only. So it is seen that 12 milligram as opposed to the 6 milligram is little beneficial, especially in the open surgery. And urinary catheters should be out post-operatively within 24 hours, unless it is required for. So assessment is very important to know which patient would go for retention requiring subsequent catheterization, and especially for epidural anesthesia, those patients had epidural anesthesia. In those cases, we can remove at the time of discontinuation of the epidural anesthesia, maybe at the 48 hours. So urinary catheter should be removed early to prevent urinary tract infection. And most of the patients can be discharged before the bowel function returns to normal. Of course, with some discharge criteria, which is very important. And this is with level of evidence to be, we should not be worried uh, uh, to send the patient before the bowel returns. So these are the all uh, recommendations and guidelines before and after 12 and 18, 2018. I don't want to go to details. I have already discussed everything. To summarize, ERAS education is very, very essential, especially at the nursing colleges, and multidisciplinary conversations needs to be happening. And second most important is documentation of everything, whatever is discussed, and whatever is done, when is the NGT removed, when the oral feeding was done. Everything documentation is important, and highlighting these goals to the patient before surgery would gain the patient's confidence to enter into this ERAS protocol and get discharged in a shorter period of hospitalization. So, as an important protocol of this ERAS, the ERAS team should follow the patients. So, till the patient is completely recovered at the home, they should follow. That is also very, very important. So, thank you very much for your patience hearing. I hope I have covered in my topic in time. I have not overshooted my time. Thank you very much.
Thank you very much, sir. That was an elaborate talk. And as you rightly said, For ERAS, what the prehabilitation is very important, and the whole team has to be in sync and have to prepare the patients mentally as well as physically for that. Thank you very much. If we get any questions related to the answer, we'll shoot those questions. As of now, we're not having any questions related to this topic in the chat box. If the time permits, can I ask you one question? How comfortable are you leaving a patient of very low anterior section without a drain if there has been any element of the obstruction prior to that surgery?
Yeah, so this is a very good question. If patient is having a very low position of the disease and we are going for ultra low, so obviously we are going for a covering ileostomy. So the ileostomy protocol is part of the ERAS protocol. It has to be properly discussed with the patient pre-operatively. Maybe you can discuss in person or maybe by by telephone with all recorded consent, so that there is no dehydration. And also the drain, also the role of drain is also controversial. You may or may not put the drain, but comfortably you may not give any drain if your ileostomy is working. So obviously there will not be any leakage. So I'm sure there is no issue even in low anterior section.
And the second part of it, which is the most controversial thing, is the mechanical bowel preparation. I think we have enough data that has actually gone against the cathartics. We might give them oral antibiotics, the IV antibiotics, but then the mechanical bowel preparation per se with the cathartics, there's a lot of data against that. But despite that, the surveys, even in European countries who are absolutely against it, say that majority of the surgeons do give some amount of the mechanical bowel preparation to their patients before that surgery. So what is your protocol in your unit if you're doing a low anterior section, very low anterior section, and that is laparoscopic? Would you give a cathartic 24 hours prior to that?
No, we do practice with mechanical bowel preparation with oral antibiotic also. And in non-colorectal surgeries, we don't give. In non-colorectal surgeries, we don't give any.
I would request the participants please to mute themselves. Sorry, sir.
So in colorectal surgery, I go for the mechanical bowel preparation plus oral antibiotic. This is routine. But non-colorectal surgery, I don't go for that. I just keep the patient NPO for 2 hours just before the surgery.
Yes, sir. There's a question in the chat box also. That's can you give an example or when the just a minute, or which criteria is there to follow in its application to emergency surgeries?
Yeah, in emergency surgery, this protocol also can be taken. And so your ileostomy is a must. In routine cases, you may not opt for ileostomy if it is a high anastomosis. So even if a high anastomosis, you should go for the ileostomy in emergency. But you can always take ERAS into the consideration while treatment. And the preconditions, the hydration has to be properly taken care before the surgery. That is very important.
Dr. Shabnam?
Yes, thank you very much. So with that, so we'll move to the second topic. So let me introduce our second speaker, Dr. Satyabrat Das. He has done his MCS Surgical Oncology from King George's Medical College in 2019, as had scored that rank through first rank in All India entrance. And currently, he is working as a senior consultant surgical oncologist at Uttakkal Hospital, Bhubaneswar, and has formerly been associated with, as a consultant with the Care Hospital, Apollo Hospital, Bhubaneswar, and Asian Cancer Institute, AMRI, Bhubaneswar. Has many publications to his credit in the index journals, and has also had an advanced training in therapeutic endoscopy from the Prince of the Wales Hospital, Hong Kong. And he's very pro and likes to popularize the robotic surgery in the field of surgical oncology in Odisha. So his topic for the day would be D2 versus D3 lymphadenectomy in colon cancer. Welcome, Dr. Satyabrat.
Thank you very much, Dr. Sabnam, for a nice introduction. So I'm not rather late and would like to start. Let me first share my screen. Just a minute.
So your screen is not visible, sir.
There is some problem. Hello.
So you're not visible, sir. Share screen option have you shared. So,
Your screen. Yeah. There's some problem. Just a minute. Dr. Phanendra, can you help me out? The problem.
sir, I'm sharing your PPT. You can just instruct me. I can change the slides.
Okay, that would be nice.
డ్రెస్ అనకి వేస్తారమ్మా సమస్య అనకి వేస్తారు సో అన్న
So I think the screen is visible.
Yeah, that's fine. Thank you very much. So today we will be. Am I audible to you all?
Yes. Yeah.
So good evening to you all. So today I'll be discussing briefly about the D2 versus D3 lymphadenectomy in colon cancer. So next, please.
Just
So basically, what we'll be discussing is the brief anatomy of the lymph node stations of the colon and the basics of the D3 lymphadenectomy and some of the robust data that that is pushing today's thoughts about the D3 lymphadenectomy. Next, please. Next, please.
some lags that I.
No, that's not. Right. So today we will be just discussing about three aspects. One is the European concept, that is this complete mesorectal excision with central venous vascular ligation, the D3 lymphadenectomy, and the D2 lymphadenectomy. Next, please. So quickly have a look on the lymph nodal stations that we all know. The red ones represent the pericolic, the blue ones the intermediate nodes, and the yellow ones that is depicted are the principal on the main nodes. Visibly, there are two lymph node stations, 203, 213, and 223 for the right colon. And for the 253, that is the main lymph node station for the left colon and the rectum. Next, please. Yeah. So what is actually the complete mesorectal excision and what is D3? And we will find in the literature that both are usually used interchangeably, but there is some difference, meticulous difference between these two concepts. Both require the central venous ligation. However, the complete mesorectal excision is a procedure which requires a greater excision of the mesorectum beyond the 10 centimeter margin of the tumor. So, and D3 removes the lymph node depending on the tumor location. That is the main lymph node, and it is limited within the 10 centimeters on either side of the tumor. Next, please. So let's have an idea about the, basically this D3 dissection is a Japanese concept, and we define, as you can see, the tumor is, the black one is the tumor, and we can see the feeding vessel, and accordingly they have divided the lymph node stations as D1, D2 along the feeding vessel, and D3 along the root of the feeding vessel, that is the main lymph node. Next, please. Whereas the CME with central vascular ligation is the concept that stems from the idea of total mesorectal excision. We know that TME is a concept that that has grown, that has changed our idea of colorectal surgeries with improved survival, decreased local recurrence, and we have seen that this thought can be extrapolated to the concept of resection of the colonic tumors during the resection of the embryonic planes. Now you can, as you can see, that majority of the colon cancer can be lifted of the retroperitoneal fascia, then the retroperitoneal plane. And if we go along this plane, we'll have a maximum chance of harvesting the majority of the lymph node, and we'll have a complete mesorectal, complete mesocolic excision with the smooth plane on either side of the mesocolon. Next, please. So just to have an idea, we have two pictures of the colonic cancer, the sickle cancer. So according to the first one, the Japanese D3 dissection removes the 10 centimeter tumor on either side of the sickle tumor with the ligation of the central vessel, whereas the complete mesorectal excision entails the removal of the more than 10 centimeter of the bowel length, along with removal of all the main lymph nodes, as well as the ligation of the right branch of the middle colic artery. So we can very well understand that the length as well as the length of the bowel, length of the and the area of the mesentery that was removed is greater in the CME with central vascular ligation. Next, please. So here is the very interesting comparison that was done by Nicholas and Hirotoshi. Found out that in both the procedures, the mesocolic resection is high. However, there is statistically increased difference between the length of the specimen, the nodal yield, as well as the amount of the mesentery that is removed in the CME as compared to the D3 dissection. So they found out, though there is a significant difference in all these parameters, the outcome is completely different. Outcome is completely same in both the procedures. Next, please. Right. So they summarize that the good prognosis after complete mesocolic excision or D3 dissection for colon cancer is reported. However, the optimal surgery there is not is still unclear, and which patient will benefit from high ligation is still unknown. And either of the procedures, either it is CME with central vascular ligation or D3 surgery, both are equally good with good oncological outcomes. So in today's discussion, henceforth, we'll use these terms interchangeably, CME or D3 surgery. Next, please. So for right-sided colon cancers, the D3 lymphadenectomy actually includes the ileocolic vessels, the right colic, middle colic, as well as the arterial arcades. Whereas the left, next one, please. Whereas for the left one, as we can see, it includes the inframesenteric artery as well as the left colic vessels. Next, please. Right. So with this idea, what is the actual guideline of the Japanese Society for Colorectal colon and colorectal cancer? Now they have advised that D3 lymphadenectomy is the must for T3, T4, or any N plus disease, and for any T1 or N0 disease, it is we can go ahead with the D2 lymphadenectomy. However, there is a gray area between the T2 tumors, so they have advised whether we can either go for D3 or D2 lymphadenectomy. Next, please. Right. So with this idea, we can discuss some of the basic trials that have come to our highlight. So the first one is proposed by the Professor Hohenberg, who initially promulgated this idea of complete mesocolic excision, and his pioneer work was published in 2009. Next, please. In his studies, he actually prospectively analyzed around 1,300 patients with colon cancer between 78 and 2002. And interestingly, he noticed that there is a drop in 5-year recurrence rate from 6.5% to 3.6% when he adopted the D3 dissection. Similarly, there is an improvement in the 5-year survival also, which has increased from 82% to approximately 89%. Next, please. So he concluded that the technique of CME in colon cancer surgery aims at a specimen with intact layer with a maximum lymph node harvest, which usually translates into lower local recurrence and a better overall survival. Next, please. Right. This is another landmark trial. This is a Japanese trial. Basically, they have included the higher stage tumors, T3 and T4 colon cancer, and they have selected around 10,000 odd patients between 85 and 1994. The primary outcome measure was overall survival. Next, please. Right. After careful study, they have found out that the overall survival between the two groups is statistically significant, as we can see in the graph. And the hazard ratio for overall survival for D3, vis-a-vis the D2 lymph node dissection, was also 0.82%. So it was quite significant. Next, please. Right. The conclusion was that D3 lymph node dissection for the advanced tumors is associated with longer survival advantage. And there is this study has provided rationale for D3 lymph node dissection in this T3 and T4 tumors. Next, please. Right. There is another trial. This is a cold trial. And in this trial, the patients with resectable primary colon cancer were enrolled in 4 hospitals in a, this is basically, I think this is a Dutch trial. And it was randomized to D2 or D3 dissection in 1:1 ratio. And next, please. Basically, the idea was to assess the safety procedure. And out of the 102 patients that they have analyzed, finally they got down to D2 patients were around 39 and D3 were 53. So out of those patients, next please. All right. Since the secondary endpoint has not reached, the primary endpoint was analyzed, and they have found that the duration of surgery in D3 is less, blood loss is less, and there were a few intraoperative complications in D3 group. However, it was around 5%, and however, it was not very statistically significant. Next, please. Yeah, next, please. Yeah, in this study, they have compared to the original study of CME with central vascular ligation. The number of the complication was quite high, and probably this is related to the identification of more of the complications and better CME quality, and it was found that the pathological specimen had a better CME quality and longer distance from the clip to the colon one. Next, please. The main demerit of this study was the small number of the patient that we have that were included in this study, and surgical techniques and all other were remained same, but there was no post-operative equal post-operative complication in both these groups. Next, please. So since the primary endpoint is not there, so they have concluded that D3 is a D3 dissection is feasible, may be associated with a better end staging. Next, please. So this is another trial. That is the RELAC trial. It's a Chinese trial, and they have studied the histologically the primary adenocarcinoma in the cecum and the right colon, and they were compared. They have included 1:1 patient with CME or D2 dissection. Next, please. Right. The post-operative complication in both the arms were same, and interestingly, there were less complication, less Clavin-Dindo 3-4 complication in the CME group, and more of, however, there was some vascular complication in this CME group, but it was acceptable and not very statistically significant. So they have concluded that although there is some intraoperative vascular injury associated with CME group, it is safe, feasible, and is in fact better. Next, please. Next, please. This trial was premature because the 3-year disease-free survival is yet to mature. Next, please. Right. This is a nice study. This is a meta-analysis which was published in 2021 and includes the comparison of complete mesocolon excision with the conventional surgeries, that is D1 and D2 resection in colon cancers. Next. And they have included around 19,000 patients from 27 studies. And post-operative complication were higher in CME group. They found that there is no difference in anastomotic leak or perioperative mortality. Lymph node harvested was greater, and there is greater overall survival and disease-free survival in the CME arm. Next. Next, please. This is another meta-analysis by the previous one, please. So this is another meta-analysis by Jasmine Crane. So they have included 31 studies, around 27,000 patients, 640 patients, and they have analyzed CME with or D3 dissection versus the conventional colonic resection. And they have found that 3-year and 5-year overall survival was higher in the D3 group, which is statistically significant. And there is 5-year DFS is also demonstrated, which is superior in the D3 arm, and it is statistically significant. Thank you. Next. So this is an interesting study, robotic CME with CVL versus the laparoscopic D2 dissection. And it is a prospective series over 3 years in a patient with right colon cavity. So they did a robotic CVL using a superior mesenteric vessel first approach. And the primary outcome was total lymph node harvest and length of the specimen. Secondary outcome they have studied is the DFS and the OS. Next, please. So interestingly, they found out that the lymph node harvest is very statistically significant in the CME with robotic procedure, which is statistically significant. P-values, there we can see 0.006. Next, please. There is a trend towards improved DFS and OS in the CME group. It is around 90 to 95% in the CME versus the 78 to 90% in the non-CME group. So basically, in the robotic arm, the basic concern is about the cost and the operating time. All other parameters, and there is also we can see that the DFS OS is significantly higher. Next, please. Next, please. Right. These trials, we have a few other trials coming up. They are the Dilemma trial and the T-Rex trial, and both are yet to mature. The first one is awaited around 2028. The results will come. This is for the left colon cancer, whereas the T-Rex study, it is actually a Chinese study, and it is for the right colon cancer. And we'll have soon the data about the D3 dissection in near future. Next, please. Right. So to summarize this CME versus the conventional or the D2 dissection, we have definitely some higher morbidity, but the mortality is same, but with better quality of surgical oncological resection specimens, better local control, overall survival, and DFS. Next, please. So as we have discussed, the extent of lymphadenectomy in stage 0 to 3 in colon cancers can be summarized. We can say that any N0 patients or any T1 tumor is safe to go with D2 surgery. However, any N plus or T3, T4 or any T2 should go with D3. However, they have also suggested that T2 tumors can go with the D2 dissection, but I would suggest that in our experience, T2 or T2, T3, T4 or any N plus in the imaging should undergo D3 dissection, formal D3 dissection. Next. So thank you very much for your patient hearing. Thank you.
Thank you very much, Dr. Das, for that elaborate talk. And I think there are many questions probably, or many discussions around it. As you already mentioned, that this was a concept that was given by Professor Hohenberger way back in 2009, and it was German S3 guidelines basically. But we've come a long way and have had a lot of studies that we've I think discussed majority of them, like the meta-analysis, which looked into 26,640 patients, and they did come up with the conclusion that 3-year and 5-year overall survival is better, of course, but there is a slightly increased risk of the complications. However, no anastomotic leaks. So surprisingly enough, there was another meta-analysis from, this was an European thing, and then the Annals of Oncology had another paper coming up and saying 18,989 patients were evaluated, and again they did reiterate that overall survival is good. And there is no difference in the anastomotic leak, perioperative mortality, but there is, however, an increase in the post-op complications. Now, I think there are a couple of things that need to be looked into. We have a recent one which has come in 2023 only, although the number is very small, 131 patients, but this one is a single center study, and they have mentioned that CME is safe, there is no increased complication rate, no increased leak rate, and obviously we know that oncologically better nodal harvest and stage migration. I think if we look at European data and this single center data, what we get from this is basically that the complication rates are something that are keeping everybody a little away from adapting this, because we know that you're going to be very close to the mesenteric vein, superior mesenteric vein, and then the whole vascularity of the small bowel is going to be jeopardized. But at the same time, if you standardize these protocols, so single center, high volume center, or the European standards, they are pretty much standard. So if we look into standardization of them, probably that inherent inhibition of moving from the conventional to this would probably go down, because then we know that we have pretty good standardized protocols, and the teams are stable, not having a shift of the teams every now and then. Especially it's very difficult to maintain when it's a high volume center and you're having a high volume of your JRs or your SRs, your PGs, getting shifted, having rounds, or coming and assisting you or being a part of the team. So I think standardization will go in a long way in making it much more acceptable than it is presently. And the other question, the other concept that when we talk about this D3, one that you very well described, CME and D3. So when we know D3 has the equivalent overall survival and oncologically similar results, so are we justified in doing the extensive CMEs all the time and not just focusing on the D3 level nodal dissections? Because now we are probably again de-escalating in terms of the appendicular cancers, where we are talking about the segmental resections, but of course going to the central vasculature. So I think randomized control trials in future would put light on that, and understanding that when we move around the loop of the Henle over there, we don't have a single, there is so much of vascular variation in right side of the colon that the commonest would be type 1, wherein you have the right colic vein and all, but not all the cases are going to have a superior colic vein or right colic vein. So would we be justified doing, going right up to that loop in all the cases of right-sided colonic cancers, or should we thoroughly study the preoperative CTs and look into the vasculature and then decide whether this patient requires the, going up to that loop or not?
Yeah, frankly speaking, I would say that CME is little more bigger surgery than the D3 dissection that we are doing right now. But as you can see, there is no head-to-head comparison between these two procedures, whether actually this is superior or that one which was proposed by Hohenberg, that is the CME is superior. So till then, I think we can safely assume that either D3 or CME both are equal, and both are oncologically safe procedures and adequate procedures also. So if we consider, if we have some data after we have this data about D3 and D2 dissection is over, I think we can have some data about the CME versus the D3 dissection in future. Maybe, but as of now, I think both are same, and I think D3 is quite enough to oncologically.
I think we have one question in the chat box, and the gentleman has asked. Yes.
Dr. Sharma, we'll take the question answers after finishing all the talks.
Okay.
Yeah.
Thank you very much.
Thank you very much.
Dr. Vikas, please take the procession and proceed with the next speaker. I think.
Dr. Arya, can you please?
Hello. A nice presentation, Dr. Satyabata sir. Now I may invite Dr. Vikas Jain for the next session. Oh, sir, you please go ahead. Over to you, sir. Hello. Hello.
Yes, sir. Yes, sir. You are.
I must invite Dr. Vikas Jain, renowned surgical oncologist, for the next session. Over to you, sir.
Thanks, Arya. Thanks, Panin. I kept this video. I've just little bit changed the topic. That's robotic APR. How actually I started doing it, because the APR, all colorectal surgeons are here and they all know that it's not a new thing. But for my younger colleagues, my friends and juniors, I'm just presenting my first colorectal video which I have started on the robot. It is not. It is the first overall colorectal surgeries for me when I started using robot. For disclaimer, I just want to tell that we are using the CMR system here, and there are some differences in all the robotic systems when we are going to make a port positioning and using them differently. Okay. So it is a case of 56-year-old female which represented the CA lower rectum, and we have taken this case after the NSCT-RT and planned for robotic abdominal resection. The positions for this APR, we used to take a semi-lithotomy position or the Lloyd-Davis positions. The benefit of this position is that it gives a good exposure and it minimizes the pressure areas. And when we are taking for the longer surgeries for 3 to 4 hours, it prevents the neurological damages for the joints and other structures, and it also prevents the compression over the nerves. So we don't take the steep lithotomy, which usually makes a lot of pressure over the joints, and moreover, it becomes difficult to place the port in CMR systems when we use the steep lithotomy position. So this is the standard positions what we are using. This is the port positioning in the APR or any this left-sided colorectal surgeries, either anteresections, low anteresections, or the abdominal resections, the abdominal part. We use the 5 ports, and this is the latest positions. But actually, I tell you that when we have started doing the this colorectal surgeries, first initially, just like the laparoscopic surgeries, I used to put a port over the umbilicus, just above the umbilicus or below the umbilicus. But with the time, I had some challenges in this port positionings when we are taking the IMS, and that I will show you in my video when in which we did with the umbilical port. But presently, we are taking the umbilical port deviated little bit on the right side and about 2 centimeters above and 2 centimeters to the right of the umbilicus. Another 4 ports we use as a standard this pelvic surgeries with these 2 ports with the operating port, one for the assistant port on the left side, just above the right side above the right iliac fossa, this anterosuperior spine, and the left side we may use the additional port for the retractors with the robot, or some another assistant can help out with this. In this videos, what I'm going to present, we have not docked the robot on this port. This is the recent photo trend of the ports what we are using. But initial days, this port also we have used with another assistant manually, and this one port, this both lower ports we used to take with our assistant, and this above left and right port along the camera that we use to dock over the robotic system. So when we start the APR, what is standard approaches with standard what we use the steps in the APR surgeries. First is the standardization of the port questions, what I have discussed and showed in the pictures. Then we, when someone has asked in the chat box also to about the medial to lateral approach and lateral to medial approach. It depends on the surgeon's preference, but we have been trained, or what we say is that we have been adapted for the medial to lateral approach, where we start taking the inframesenteric artery first and then go laterally towards the Tolles fascia or Tolles line. And especially in the female patients, we used to take the uterus or the peritoneal reflections in the sutures and tie it to the intra-abdominal wall so that it doesn't interferes in our visual field. Then after taking the IMA, I'll show you in the video step by step. This we used to take the ureteric identification and we dissect just above the ureter. Then we go for the mesenteric plane dissections, and later on we'll show you perineal dissections. I will come back after showing the abdominal video presentation. Here, first of all, we used to identify this aorta and the IVC. We can see very clearly this is the IVC and this one is the aorta where my scissor is there. This is the CMR systems. Left side, we can see that's green color. This is the fenestrated grasper we used to take. And the right side in the yellow color, we can see this is the scissor port. This yellow shows the cutting mode of the cautery, and most of the times we prefer the cutting mode of the cautery because in cutting mode it creates less charring and less smoke, and we don't find any much difficulties when we are using the scissor with the monopolar while we are dissecting in cutting mode. And in the fenestrated graspers, we used to interchange with the either with the bipolar or we keep the fenestrated graspers for the dissections or for the holding this in this fascias and the layers. So after identifying the aorta, we used to follow at the origin of the inframesenteric artery. Here we can see the inframesenteric arteries lying over the aorta. We dissect along the inframesenteric arteries and we try to denude it at the till the root of the origin of the inframesenteric artery. But unfortunately, as I told that this is the first case and we had some initial difficulties in the port placements when we have kept it on the umbilicus. So in that positions, we used to have difficulty in reaching up to the root of the umbilicus when we used to rotate the camera from above inside. So we have raised the IMA, but we didn't take the IMA exactly at the origin of the IMA in this case. Here on the left side, we can see the ureter. It was a very thin patient, very thin lean lady. So the ureter was visible even before we started the dissection of the vessels. This was the very first case, and truly telling you that there was no guide or observer was standing along with me in this case. This is the lymph nodes lying over the aorta. Sometimes, if it is visible, we used to remove that one also. So although it comes like Dr. Satyabrat has explained the D3 type of dissection. Here, after making a plane over the aorta, we are dissecting along the inframesenteric artery, and we are carrying this plane to dissect to reach out the non-vascular plane of TME. And after raising the IMA, we are trying to get reach the at the root, but as I told, it was difficult for us in this case because the port placement was hampering. And whenever we used to move at the extremes of the ports in the robotic systems, it used to give a pressure alarm. Whenever there is excessive pressure over the port, it is not in our control, it gives the pressure alarm. So we have to abandon our movement in that direction, then we have to reset the port until unless we are getting habitual of how much movement, how much restricted movement we have to make, and as little possible movement, as small movements we do, it gives the better dissections and it gives less alarms and less restrictions while we are doing in the robotic surgeries. One point our beginners has to keep in mind that as like most of the places in the body, the arteries runs along, veins also runs along the arteries, but in IMA, the IMV doesn't runs along the IMA. And most of the cases, we may not need to divide the IMV in any colorectal surgery. Sometimes until we are going very high for the margins, then we may have to divide IMA, but it is not always necessary. Here we can see that in this case, that's we have taken the IMA a little bit far away from the root of the origin of IMA. Though we have dissected, we have taken out most of the lymph nodes along the IMA, but it was difficult in initial phase to reach at the root of IMA. After lifting the IMA, we will get the avascular plane of the mesentery. Here we have changed the this fenestrated Jaspers again with the bipolar cautery. Bipolar is shown in the blue color. It shows the bipolar mode, and here the yellow color shows the monopolar mode. So most of the dissections we are doing it here in the monopolar cautery with a very low cautery setting. So you can see that we don't see so much of
ଖାଇନି ତ ଆପଣ ବାହାର ପଡେ ନମସ୍କାର କେମିତି ଅଛନ୍ତି?
sorry for interruption. So as low as we keep the settings for the cautery, we will see less of the smoke and less of the charring in the tissues. Now we can see the ureters coming from below also. From the medial side, we can expose the ureter now. It is visible here. And just above these bifurcations, we can see the avascular plane. Here comes most of the nerves which we have to preserve for hypogastric plexus. As soon as we got this avascular plane and we keep maintain of this plane, these nerves can easily be preserved. Oh, sorry. First, we get the avascular plane in the posterior space so that we can get the actual extent of the dissections where we have to go. It will define the TME plane much better if we start from the posterior side because anteriorly we have to see in the male patients where is the seminal vesicle or where is the this, bladder and other structures. But in the posteriorly, exactly we get the avascular, complete avascular plane. So we don't bother about any great vessels or any other structures posteriorly, and we get the very beautiful TMA plane without any bleeding or any visible interference posteriorly. Parallelly, I'm dissecting along the ureters on the lateral side so that ureter can be taken down and can be lateralized well. I hope for time saving, I can forward the video a little bit. Here it comes on the right lateral dissections. Right side, we don't look for any ureter or any other structures significantly because the sigmoid and rectum is more over the left side structure. So right side ureter doesn't comes in the field. Here we just after getting into the TMA planes, we need to bother about only the rectal vessels which we have to ligate or we have to take the vessel sealers, to control those vessels. And in robotic surgeries, in CMR systems, we don't get the vessel sealer, so we used to take the assistance of our bedside assistant. They used to take the ligashos from the right iliac fossas uh, port where I open the spaces and they used to coagulate. On the both side, only the point what we have to take care of the nerves which are running along the floor of the pelvic cavity that has to be saved and preserved. Now we are just about to reach the pelvic floor. After completing this. When I started this robotic case, initially I used to try to control everything with this bipolar, and I was not habitual to take the assistance of my bedside assistant. So this bleeding again in recent cases it has been stopped because after starting the bleeding, I used to ask my assistant to just coagulate, coagulate, coagulate. But initially I used to try it with bipolars only. So when you get that you are about to come with the rectal vessels, always try to take the help of your assistant for vessel sealing devices. After completing the mobilization on the both side, we used to progress towards the anteriorly, and after taking this anterior peritoneal fold, we used to take rectum down, and always as a dictum, this what which help us to differentiate it from the uterus or the seminal vesicles. That's always follow the fat, as the fat belongs to the rectum. Here the uterus we have already lifted up in the sutures, and this uterovesical fold, this uterorectal fold has been dissected. Oh, I'm so sorry. When we get the plane from medial to lateral dissections, somewhere we have to open a windows which opens into the lateral side, and then we can come back to the lateral side of the colon, and we can start dividing the toes line. Nothing much remains after on the lateral side when we have completed mobilization from medial to lateral. Here again comes the advantage of robotics actually. Then we can rotate our hand in any directions for 360-degree movement. We can come from above, we can come from below, and from where anywhere we can take a cut over the surfaces. Here again, for my younger colleagues, that whenever you are going to start doing this robotic surgeries, always take as much as help possible from your assistant. Here again, I'm just struggling to take the cut from this part. Even if I have asked to my assistant to lift it up, it will be very easy to take a dissection cut from here. Again, the rectal artery is on the left side. just because of these interruptions. This is the place where the nerves again can get injured, and this is the place where bleeding can occur from the rectal arteries again. So there we have to take care. Now we can see the pelvic floor is visible here. The muscle fibers are seen from the levator and eye. Posteriorly it is completed. Anteriorly we are just about to do it. After circumferential pelvic floor mobilizations, the abdomen part gets finished, and then we have to proceed for perineal part. Perineal part I have not recorded as a video, but I will just give a small theoretical discussion over it. Before doing the robotic surgery, it was very difficult for me to visualize this levator and eye muscles of pelvic floor so clearly. In the deep pelvis, it is always difficult to stabilize the camera with my assistant in laparoscopic surgeries, and when we are going for open surgeries, it was extremely difficult to visualize this area. So we have completed the pelvic floor as we have reached on the pelvic floor from posteriorly and on the both side, and laterally anteriorly we have completed almost, leaving except the vaginal part. Now after doing that, so we have to resect the level of dissections where we have to resect the segment. Um, just above the inframesenteric arteries insertions, we used to take a cut. Before doing, we don't use the staples to divide it, and we ligate on the both side before dividing the rectum. And then when we take a cut after ligating it, the suturing and knottings becomes very fantastic when we are doing in robot. This part of the video that we are showing is after taking out the excisions with the perineal part and the perineal closure. We used to do the peritoneal closure also as and when it is possible. This is the last part of the abdominal perineal resection. We keep the drains only in the perineal in the pelvic part. We don't keep the drains in the abdominal part, because most of the APR patients are the post-radiation patient. They used to have a poor wound healing in the perineal wound, and we see a lot of patients of the wound adhesions in the perineal regions after collections, after the perineal collection, so pelvic collection. So it is always better to get it drained in the perineal drains. So thank you very much. I have completed my first APR videos shared with you, and I hope if you like such type of videos, you can see such videos on YouTube also. What I have done in the laparoscopic and robotics, you can scan this for my YouTube channel, and I'll be happy if I can get any comments from our expert panelists or and can help me in improving my knowledge. Thank you.
That was an excellent presentation, Dr. Vikas. You showed the closure of the peritoneum there. So if you're not able to close that, would you like to place anything else, or do you get the omentum over there, or how do you manage that?
Yeah. Sometimes we put a sleek of the omentum there.
Have you ever tried those balloons, Baker's balloons and all, for the to prevent
I've
the
seen Dr. Amir Prasad
MTBS
use that
syndrome?
balloon. Yeah, this
Yeah.
Bagota's balloon. I have seen him using it, but I have not used it. Even I have not seen that one actually. Except videos, I have not seen that.
Some people, they say that Jugaad, some people have started using the Foley's catheter. They keep it inflated for a few days, at least 3-4 days, and then pull it out.
I don't think Foley's catheter has that capacity to fill the pelvic cavity, but that bag may really help. And this momentum helps, but other than that, a lot of flaps are also explained, and we can see that's a gluteal turnover flap for the this levator ani closer when it is not getting closed primarily, or for pelvic cavities, even the rectus muscles flaps. A lot of flaps have been explained to fill that gap, even other than momentum.
Hello, Dr. Vikas, Dr. Prashant here. So it was a wonderful presentation.
Dr. Prashant.
Were you using the three arms of the robo, or were you using just two arms of the robo? Like this.
As I told that it
CMS
was my first case. Previously we were using the two arms. Okay, but nowadays we are using the three arms. We are using the fenestrated grasper and bipolar, which is all three are using together. But initially we were dependent more on the assistant for the port. This fenestrated retractor part we are using with our assistant.
My next question is did you face any problem while mobilizing the left colon in the CMR system? Like reaching up to
Actually,
the
most
splenic
of the
flexor,
Indian
have you?
patients we don't need to mobilize. Yes. In that case, actually, yes, we have to plan the docking accordingly, because if we do the splenic flexor mobilization with the same this docking, it becomes very difficult. So in that case,
Yeah, it tends to
we
hit
take the
in
splenic
between the
flexor
arms and
mobilization with laparoscope. Yeah, we do the splenic flexor mobilization with laparoscopy.
that's good. That's I think that is
We
a
make it as a
better jugaad
hybrid
than
procedure. Yeah.
trying to shift the arms.
Yes, it's difficult. It's take a lot of time rather than displaying flexor mobilization. We just switch over on the laparoscopy, finish it, and then we come back to the robot.
Yeah, that's wonderful, and that's more practical also. We had a question in the chat, what is the cautery settings that you use? This was from Dr. Umesh Raj.
Cortis settings, we're using the 15 for the coagulation, and the 10 for the cutting. We use very extremely low. Yeah.
And we had one question from Dr. Pranav Prushti. like what should be the approach for dissection, posterior then lateral followed by anterior, or are there any specific advantages to them?
Yeah, it is standard actually. The most of the all people we used to follow from the posterior because it's the avascular plane we get posteriorly, and no other significant structures comes posteriorly other than if we go deep and go for the damage the sacral plexus. Other than that, nothing comes posteriorly. So we always prefer from the posterior so we can define the exact extent where we have to go. Then we go for the lateral where only the lateral vessels comes and no major structures comes except that when we have lateralized the ureter. Anteriorly, we have to take care. So we used to go anteriorly at last. First thing that's if we do anteriorly, this blood drippings come from above downwards, and other than the prostatic plexus, this fascia and vaginal, this all structures where we have to dissect carefully that prostatic plexus bleeds can irritate our field a lot. So anteriorly, we do it last.
Thank you. I had one
I
more
think we
question.
had. Can I chip in?
Like, pardon?
Can
Yes,
I
Dr.
chip in?
Shabnam.
So I think
Sure, sure, sure.
it more or less depends on what center you have been trained from, and there are
Yeah.
many people who are doing it differently. And I was trained in TMS, so the protocol over there with Dr. Saklani was that you would do the posterior, then anterior, and then would be more comfortable going lateral after that, saying like 76% would have middle rectal, although it would be in 50% would be just unilateral, but it gives a better control of the middle rectum and the plexus over there. So I think whatever centers, it's for the sake of juniors, they're being trained in because they're proctored in those centers, so they should try to stick to that unless they're confident enough to change that approach, whichever approach their proctors or their seniors are having.
Yeah, definitely, I agree with you, Dr. Shabnam. That wonderful. Similarly, I also follow the same protocol, like going first posteriorly, and then going anteriorly, and leaving the lateral stalks for the last, because I think it gives a better control for the uh, vascular control for the lateral stalks easy. But when I saw Dr. Vikas doing it so beautifully, I thought, why not adapt this one also? This also beautiful modification of the technique. Uh, uh, One more
Actually, we prefer
question.
lateral because when we have made the posteriorly, this lateral planes comes in continuation. So that's why
Yeah,
we
yeah, yeah.
use the lateral after doing the
Yeah, you are
posterior.
right about the crippling. The
And
blood
yeah,
fluid comes dribbles down, and that definitely hinders our vision. And what has been your experience on intersphincteric dissections using the CMR robotic system?
interesting to the sections, this perineal parts makes a difference. Abdominal part doesn't make much difference, I believe. But we have done only 2 cases for intersphincteric sections after doing starting from this CMR system.
There was one more question from Dr. Pranav Prushti. Is there any role of radiation therapy in early stage rectal cancer?
We have Dr. Arya with us. I think he will be the best person to reply this. Dr. Arya.
Yeah. Dr. Arya Pandata, are you there? Dr. Arya?
His such connection is not there.
Okay. And do we have any radiation oncologists among us?
No, we kept only Dr. Arya with us.
So if I can chip in and make it short, like so basically anywhere where the circumferential dissection margin is threatened, or we on preoperative imaging, the clinical imaging, if there are any presence of mesorectal stranding or nodes, those are the cases where preferably radiation should be preoperative radiation is mandated. If it is a T1 or T2 tumor, a rectosigmoid or upper rectum, which is limited to the mucosa, submucosa, without any mesorectal nodes or mesorectal spread, then definitely radiation can be omitted in those cases.
Dr. Umesh has asked there, what is the initial surgeries one should attempt as a beginner in robotic surgery? Umesh, it depends actually on what this center you are working because we are doing only on the cancer surgeries. So for us as a cancer center, I have started doing it from the hysterectomies only. Hysterectomies for me is the simplest surgeries for robotic surgeries as a beginner. But for general surgeries, I'm not sure because maybe the left chole will be the standard simple surgeries for most of the general surgeons.
Another one from me, Dr. Vikas. Is there like
Yeah.
when you're dealing with a male pelvis, is there any modification want, or
Hmm.
what would be your take on it? Like the video you showed was for a female pelvis, which tend to be broader, and what I would say they are a little more easier. But what about the male pelvis? How
Yeah,
would you
that's what I
modify your
told that it
steps,
was
or
my first case.
what
That's what
would
I'm
you?
saying. It was first case, so I choose intentionally. Yes, this female pelvis, thin lean pelvis, but it was the post RTCT. So fortunately, I didn't find any problem with the radiation effects in the pelvis after this new adjuvant edition. But in the male pelvis, often definitely it becomes narrower, and the clashing of the instrument is quite common even in the robotics also. Other than that, for a robotic pursuit, there is not difference. Even it becomes easier because of the better visibility and the better movements. We can rotate the Caesar in any directions. We can rotate the instrument in any directions. We can see the planes in better way because we can retract in accordingly. Whatever. And another thing, the camera is in our hand. In laparoscopy is when someone other is assisting us. So it is difficult to manage two people in the same place, and this camera movements is a smaller movement becomes difficult in the pelvis. So robotic gives definitely an advantage to keep a stable camera in, especially in the male pelvis.
On a lighter note, robotic has a disadvantage that you cannot blame anybody, not the
Yeah.
assistant. So I just wanted to know whether you were trained on the CMR first place or you were trained on Da Vinci.
Only CMR.
No,
I
so
have not used
Da
Da
Vinci
Vinci.
has
Yeah.
I got trained on Da Vinci, and I think CMR has a an advantage that you don't have to stick your head into that zone all the time. You move your head and your
Yes.
instruments get frozen.
Yes.
So I think it's a big advantage that has come up with these newer robots that we have. I've not tried my hands on any of them as of now. The Hugo is there. I think Mantri is there, and then the CMR. I think they have they are even much more comfortable for the surgeon because you can sit on the console without your head stuck there, and you can watch your assistant, your patient, and do your surgery at the same time.
Right.
And it is
But
here to
the
stay.
advantage in
Not
this
for
is,
cost. Every laparoscopic surgeon would want to shift over because of the ease, the magnification, that
yeah.
dexterity and the articulation and all that you get. Of course, if the cost is not an issue, I think everybody would want to jump in.
I hope even the cost will also get reduced a lot because the patent
Yes.
has over and a lot of competition is there in market. Yeah. Even
True, the
this
monopoly is gone, and the costs have
insurance companies are
exponentially come
also started
down.
covering it. Yes.
Thank you, Dr. Vikas. It was an excellent presentation, and I guess we have answered all the queries beautifully. Over to Dr. Fanindra now. Fanindra,
Thank you.
unmute.
Yes, sir. Yes. Thank you, respected faculties, for sharing your valuable thoughts and sharing
Fernando,
your valuable time, busy schedule.
Fernando,
Yes,
Fernando,
sir.
there are few
Hello.
questions remaining in the chat box, I think.
Okay, sir. Okay, sir.
Someone has asked us regarding the margin. Should we follow the pre-anesthetic extent or the post-anesthetic extent in case of rectal cancer? Dr. Subrat, Dr. Subrat is there? Sorry, Dr.
Sir
Satyadar
is,
Das.
I think he's dropped out.
Okay.
Uh,
I
Dr.
think Dr.
Prasad, sir,
Prashant can join in for it.
It is not showing at my end. Can you please repeat the question?
regarding margins in rectal cancer, should we go post-anesthetic or pre-anesthetic margins?
No, the rectal cancer, the dictum is always that the therapy is planned, the total therapy is planned initially itself. So the margin status is always determined according to the pre-anesthetic planning.
Okay. Another question is that the D3 or D2 technique is better resection starting in the middle of the root of SMA or IMA, or it is better starting from the told fascia to midline? I think I have explained this one in my presentation. It is on the exposure and the techniques, whether we are going from medial to lateral approach or the lateral to medial approach. Okay. And the another one was, what are the recommended number of nodes to resect in colon cancer? It is standard in NCCN, I think it's 12, right?
As per the CAP guidelines, 12 are the minimum that you address see. The more the better.
Yeah.
So just a question from my side, sir. Do the pathologists over there are now following the mesocolic cell concept, or they are following the same standardized concept or number of lymph nodes?
Pathologists also always follow the CAP guidelines.
Sure.
We can finish it after.
Okay, sir. Thank you so much, respected faculties, for sharing your valuable time and in your busy schedule. I hope this session helps our residents and young surgeons like me to change the practice or modify the practice in colorectal cancers. I'd like to announce our next session, that is going to be on journey of bariatric surgery on 11th August 2023. The timing will be the same. And for those delegates who have not yet joined our TUGSS group, I would request them to join our TUGSS group by scanning the scanner QR scanner shown over the screen, and you can follow us also in the Twitter handle. Can we conclude the session, sir? Vikas, sir?
Yes, definitely.
Thank you so much. Good night.
Thank you very much for the invitation. And I must say that Dr. Vikas, as the chief of TUGSS India, is doing an excellent job. Academics is something very, very important, and it's very difficult to keep on pulling so many programs, in your busy schedule. Thank you very much for having us here.
Thank you.
Thank you. You have made actually this program is very interactive. Thank you.
Pleasure was all mine. A very good night to all.
Thank you all. Thank you very much. This session is recorded, so this will be uploaded on YouTube very soon for all, and I'll inform all the panelists and speakers also whenever it is available on YouTube. Thank you.
Thank you, Dr. Vikas. It was wonderful interacting with you. Anindra. Thank you.
Thank you.
Everyone. Good night.
Good night.
Thank you so much.